Good afternoon and welcome to the Center for Psychiatric Rehabilitation webcast series. I'm Sally Rogers, the Director of Research at the Center, and it's my pleasure to introduce to you Dr. Kim Musser, professor from Dartmouth University and a preeminent researcher in the field of mental health and psychiatric disability. For many of you, Dr. Musser requires no introduction because of the many contributions he has made to our field, especially for people with mental illness and substance abuse disorders. However, by way of introduction, I'd like to review with you some of the many contributions that Dr. Musser has made. Dr. Musser is a licensed clinical psychologist with a doctorate in psychology from the University of Illinois at Chicago, obtained in 1984. From 1987 until 1984, he was a professor at the University of Pennsylvania Medical School. In 1994, he joined the Dartmouth faculty and is now a professor in the departments of psychiatry and community and family medicine. Kim's areas of interest include the psychosocial treatment of severe mental illness, post-traumatic stress disorder, and dual diagnosis. He has published over 150 peer-reviewed articles, approximately 100 book chapters and manuals, and has given hundreds of presentations to professional groups. Dr. Musser also serves on the editorial board of several professional psychology journals and is involved in many other psychologically oriented activities. On a personal note, the Center for Psychiatric Rehabilitation has been very fortunate to count Dr. Musser as a colleague and advisor. He is always insightful, helpful, thoughtful, and forthcoming with information, which has been a great benefit to us at the Center. Without further ado, I'd like to introduce you to Dr. Kim Musser, who will present this webcast on the integrated treatment of dual diagnosis. Thank you.
Thank you very much for the introduction. It's always wonderful to be here at Boston University. So many good things have started here and continue to be done here. I'm going to be a little bit fast in my talking today because I'm going to try to cover a little bit of everything. And with that in mind, let's start off with a little preview of what it is that I'd like to cover. I'm going to start off and I'm going to talk quite briefly about the effect of substance use problems on people with severe mental illness, in order to make sure that we're all on the same page in terms of understanding the scope of the problem. I'm then going to talk a little bit about limitations of traditional parallel or sequential approaches to working with people with dual disorders that don't attempt to truly integrate the services for the treatment of both of the disorders. Then I'm going to lay out the principles of integrated treatment, beginning with the definition of what integrated treatment is, and then talking about core components of integrated treatment programs. In particular, I'm going to focus on the component of stage-wise treatment that's tailored to individuals' motivation to change, and that motivation may depend on the person's mental state in terms of where they're at, in terms of learning how to manage their psychiatric illness and learning how to manage and to conquer their substance use problems. Then I'm going to shift gears and talk a little bit about research. I'm going to talk about controlled studies of integrated treatment for dual disorders. And then I'm going to talk about a little bit about some new areas. I'm going to talk about a family intervention program that has recently been developed and is currently being evaluated. I'm also going to talk a little bit about pharmacological treatment strategies. Then we'll try to take a few questions. So with all that in mind, you can see why, if I speak a little bit fast, I hope that you'll forgive me. But for those of you who miss some of the things that I say or who would like more information, first of all, this PowerPoint presentation will be made available through the web, so you can download that and look at that. And then second of all, if you want lots more detail, it is now available in a book that just came out last year, published by Guilford Press, that is widely available in paperback and at a pretty cheap price, which is nice. So with that having been said, let's talk about what probably everybody already knows, which means that we don't need to get into a lot of detail about it. But that is the fact that substance use and abuse is associated with the worst course of psychiatric illness with respect to pretty much every possible domain of functioning. There's tons of research showing that the use of substances, alcohol, cannabis, cocaine, opiates, and so on, is associated with the precipitation of relapses and rehospitalization, can lead to significant economic problems, as consumers often spend the limited money they have on substances. It can lead to great amounts of family conflict and a high level of strain in close relationships with other people. It can lead to economic problems. Well, I mentioned economic problems, but medical problems, housing problems, and of course legal problems because of the unlawful nature of much drug use and because of the disinhibiting effects that substance use has. One of the upshots of substance use in the population of people with severe mental illness is an increased vulnerability to trauma and also to infectious diseases. In fact, what we find is that people with severe mental illness are at increased risk to a wide range of infectious diseases, but most significantly to hepatitis C, which of course is the leading cause of liver transplants in this country. And the number one predictor, or the number one contributing factor to infectious diseases is drug use. So there are many, many problems associated with substance use in terms of the exacerbation of psychiatric illness. And efforts to address substance abuse in this population, of course, are guided by the goals of trying to improve the long-term course of the illness and to empower consumers to take back control over their lives. So for all of these reasons, addressing substance use problems in people with severe mental illness is of the highest priority. Well, let's talk just for a minute or two about barriers to treatment, problems that consumers have often experienced in traditional treatment systems for psychiatric and substance use problems. Traditionally, approaches to treating dual disorders comprised primarily of either parallel approaches or sequential approaches. A parallel approach is where you would have a substance abuse service located in one setting and mental health services located in another setting, typically funded by separate funders with different eligibility criteria. And the expectation is that people with dual disorders are supposed to get treatment for both of their disorders, but from those separate agencies. So the services are delivered, in theory at least, in a parallel fashion. There are many problems with parallel service delivery. Perhaps the most important problem is the lack of coordination, to say nothing of the lack of actual access to both services. In fact, sometimes substance use services or mental health services actually prohibit the provision of services to people who are receiving services for one of those other disorders. There are other problems too in terms of accessing those services. And even when services are accessed, often there's a lack of integration between the two. And sometimes services can be actually in conflict with one another. So there are problems in terms of parallel approaches, both in terms of accessing services and in terms of delivering both mental health and substance use services in a cohesive and integrated fashion. The sequential treatment approach refers to trying to treat one disorder first, followed by the treatment of another disorder. And the idea is that if you try to treat the so-called primary disorder, and nobody can really tell what's primary and what's secondary, but if you could tell which was primary, which was more important, would it make the other disorder go away? And so efforts to treat one disorder followed by another disorder are based on the assumption that when you have people with co-occurring or dual disorders, often one disorder is more primary than the other. So the idea being, well, you have a person with bipolar disorder and they have frequent bouts of drinking. If we could stabilize the bipolar disorder, maybe the drinking problems will go away. Or if we have somebody with schizophrenia who uses substances, and those substances exacerbate symptoms, such as the use of cannabis. Well, gee, if we could get the person to stop using cannabis, maybe it wouldn't exacerbate their schizophrenia, and it would be well managed. Now, the trouble with sequential treatment approaches is that it fails to take into account that psychiatric illnesses and substance use disorders interact with one another, that it's extremely difficult to successfully manage bipolar disorder without addressing concurrent substance use problems. And similarly, it's extremely difficult to address substance use problems in somebody, say, with schizophrenia without attempting to address the schizophrenia. So, in fact, the trouble with sequential treatment approaches is that they don't take into account the fact that that one disorder feeds upon and can worsen the other disorder. And that makes it inherently more difficult to successfully treat one disorder without attending to the other disorder. Now, the problems with sequential and parallel treatment approaches were pretty well recognized, actually, by the late 1980s and the early 1990s. And those problems led to the development and formulation of models of integrated treatment for co-occurring or dual disorders. Well, when we talk about integrated treatment, And there are a number of different models out there, but in truth, the models probably share or have more in common than they differ from one another. When it comes to defining integrated treatment, at the most basic level, an integrated treatment program can be defined as one in which the mental health services or the mental health problems and the substance use problems are treated at the same time by the same clinician or by the same team of clinicians, and in which those clinicians assume the responsibility for integrating the treatment of the two disorders. Now, the notion of integrating the treatment for the two disorders actually can come quite naturally if the treatment focuses on and examines the natural interactions between mental illness and substance use problems. And just to give you a few examples, we know that sometimes people with major mental illnesses have difficulties establishing and maintaining close relationships with other people. And yet they, like everyone else, have a need to have love and closeness and friendship and acceptance in their lives. And sometimes people get those needs met in part through social contacts with people who have substance use problems themselves. And that can lead to substance use problems. So I ask you, if we help that person develop alternative social contacts and better social skills and ways of connecting with people other than through using substances, are we treating the psychiatric illness or are we treating the substance use problem? And clearly we're treating both. And there are many other examples. For example, sometimes people use substances in order to cope with psychiatric symptoms. And yet we know a tremendous amount about how to help people cope more effectively with symptoms. So if we help people cope more effectively with symptoms, again, are we treating the substance use problems or are we treating the psychiatric illness? And the answer is that we're treating both. So in effect, integrated treatment means treating both of the disorders at the same time by the same team of clinicians with a particular eye towards understanding the interactions between the disorders. Well, that having been said, what are some features of integrated treatment programs? I mean, once you're integrating the services, you still need to provide a certain core set of services. What I'm going to do is I'm going to describe basic fundamental ingredients that integrated dual disorder programs strive to incorporate, or to the extent that they incorporate these ingredients, those programs tend to be more effective. Now, the specifics of the programs vary. It's typical for programs to provide a variety of different psychotherapeutic formats, ranging from individual work to group work to family work. But overall, what many programs seek to do, what the most effective integrated dual disorder programs seek to do, is to provide some amount of assertive outreach, and I'm going to go through each of these in a moment, meaning the provision of services in consumers' natural living environments. They have a long-term commitment to providing services over an extended period of time and don't impose artificial time constraints. They're comprehensive in that they address the wide range of needs that consumers have. They focus on taking advantage of opportunities to address and to reduce the negative consequences of substance use problems, never allowing a person or assuming the philosophy that it's best for a person to hit rock bottom. And then last of all, programs that are most effective have a sensitivity to the individual stages of change, the individual motivation that a person has to change his or her behavior. And by having that sensitivity, programs are most effective at being able to optimize outcomes by matching interventions to consumers' stages of change or stages of treatment. Well, let's go into each of these in a little bit more detail. Assertive outreach, of course, refers to the provision of services in consumers' natural environments, most typically in their homes, in an apartment, the home of a family member. It could be at a coffee shop or at a park bench or some other kind of a public place or a library or a YMCA. The primary reason that assertive outreach is important is that many consumers with dual disorders are not active participants in treatment, or they may sporadically be involved in treatment, but many of them, especially during the height of substance use episodes, are not actively engaged in treatment. And if you want to engage people and develop a working relationship and begin the process of motivating people and instilling hope, often you need to do it on their terms in settings that they're most comfortable with. And that often means in the community. Another advantage or another reason why assertive outreach is important is that it provides you with more opportunities for engaging individuals in the consumer's social network. I mean, there's a lot of research already showing that the more people in someone's social network who use substances, the more difficult it's going to be for that person to attain sobriety. And at the same time, we know that family relationships are tremendously important to people with major mental illnesses, and also for people when they have an active substance use problem. So being able to go out in the community and connect with people in their natural living situations provides additional opportunities for connecting with those significant others. A final advantage of doing assertive outreach is it often provides you with important information about the environment in which a consumer lives, and may provide helpful information about the course of the dual disorders as well. Long-term perspective is based on a recognition that severe mental illnesses are often long-term, even though many individuals attain recovery in the long term. Many individuals continue to have a need for ongoing services. And in the same way, although for some people substance use problems may be time-limited, for other individuals it's often a chronic relapsing condition. People may have a relapse after significant periods of sobriety. And other people still may not even achieve a full remission of their substance use problems. And in the same way that an ongoing commitment to working with a person and addressing their needs in ways that they define important is critical for the management of a psychiatric illness, it's also critical when the person has a co-occurring substance use disorder. And that is in preference to imposing artificial time constraints on the provision of services. Comprehensive treatment is based on a recognition that people with co-occurring disorders have a wide range of needs. And those needs run from the need to improve their ability to cope with persistent symptoms, whether it's hallucinations or delusions, anxiety, depression, sleep problems, post-traumatic stress disorder symptoms, and the like. People have a need for help in improving their capacity to cope effectively with symptoms and to reduce the distress that symptoms cause. People have a need to have good quality relationships with their family members. May have a need to help to overcome the debilitating effects of traumatic experiences that they may have had during childhood and in adolescence and after they developed a mental illness. People have many other needs as well. They have medical needs, which we've already briefly talked about. They may have needs in terms of parenting skills, especially women with a severe mental illness and a dual disorder often have children. And those children are maybe vulnerable to neglect, and yet those mothers have a tremendous desire to be good parents, and so they have a need for parenting skills. There's a need for housing. There's a need for many other types of basic services. And so an effective integrated treatment program for dual disorders is one that addresses the wide range of functional needs, as well as needs in terms of the symptoms of the psychiatric illness and basic social needs as well, rather than being something that's narrowly focused on substance use behavior. And reduction of harmful consequences. Reduction of harmful consequences refers to efforts to try to minimize the negative effects of substance use on a person. Those effects could be, for example, we know that use of dirty needles can lead to infectious diseases. So needle exchange programs are a form of reduction of harmful consequences. Teaching safe sex behaviors to individuals who may exchange sex for money or for substances would be another example of the reduction of harmful consequences. There are a number of reasons for thinking that reduction of harmful consequences is an important component of any integrated treatment program. First of all, we know that many people with co-occurring disorders improve gradually over time. Now, some people see abstinence as a goal and endorse it as a goal from early on and strive to achieve that. But for many other people, the pathway to abstinence and sobriety is through a gradual reduction. And therefore, the need and the desire to reduce the harmful consequences becomes critical so that they're able to be around and to be working towards sobriety in the long run. Because many of the consequences that we're talking about reducing ultimately can lead to premature mortality. Another important reason for using strategies that attempt to reduce harmful consequences of substance use is that it represents a way, or it is a way, of establishing a relationship with someone. It demonstrates caring to the other person. And that caring can form the beginning of a bond, a therapeutic relationship with the individual that may over time lead to the development of motivation to work in a concerted way towards reducing one's substance use problems. There are many examples of strategies for reducing the harmful consequences of substances. I mentioned needle exchange and safe sex lessons. I also think that family intervention can be conceptualized as an approach aimed at reducing harmful consequences. And the reason is that we know that people with co-occurring disorders impose or create greater amounts of stress in the home. And we also know that when stress in the home becomes overwhelming, sometimes what happens is that family members are unable to cope with that stress, and eventually they withdraw their caregiving, their psychological and economic and other kinds of investment in the consumer. And the withdrawal of that support is associated with the worst course of illness. And in fact, research by Robin Clark has shown that family involvement is directly related to consumers needing lower levels of professional involvement for their dual disorders, and is associated with a better outcome of the dual disorder. So the early stages of family intervention following the engagement of the family in the treatment process are actually aimed more at reducing the negative effects of substance use on the family than trying to actually direct the substance use behavior itself, which is more of a longer term goal. So I see that as yet another type of strategy designed to reduce harmful consequences of substance use. And let's get now to the last of the different components of effective integrated treatment programs, and that is the use of a stage-wise treatment approach. Now, the concept of the stages of change or stages of treatment is based on the notion that when people are in the process of changing a behavior, in particular changing a behavior associated with health consequences. So the concept of stages of change has really been developed usually around, or was developed mainly around health-related behaviors such as smoking, weight gain, and then applications to substance use problems. The notion is that when people are going about changing behavior, that change process goes through a series of discrete stages, and that at each stage the person psychologically is at a particular place in that change process. And understanding that change process can be important in terms of helping the person get to the next stage. Now, the stages of change were first described by James Prochaska and have been tremendously influential in really the psychotherapeutic field. And those stages of change included pre-contemplation. I mean, pre-contemplation, you're not even thinking about changing. And then contemplation, you're thinking about it, but you're not changing. And then preparation, you're beginning to make plans to change. And then behavior change, where you actually undertake changes in one's behavior, whether it's smoking, drinking, or some other kind of behavior that you're beginning to change. And then maintenance. And so each of those stages of change represent psychologically different spaces in which the person resides for a period of time. And understanding that space becomes critical in terms of helping them get to the next stage. Now, the stages of change were adapted at our research center by Fred Osher and Lyle Kofed about 15 years ago. And they were adapted to refer to stages of treatment that people with dual disorders go through when they participate in professional-based treatment for their disorders. And so the stages of change really map onto the stages of treatment. But the differences are that the stages of treatment refer to the process of getting and being involved in professional help. And the stages of treatment also have very direct implications for the selection of treatment strategies based on an individual's stage of treatment. Now, the stages of treatment, as I said, map onto the stages of change. And those stages include the engagement stage of treatment, the persuasion stage, the active treatment stage, and the relapse prevention stage. And what I'm going to do for each stage is to briefly walk through them to give you a little bit of a clinical intuition, the idea behind each of those stages. What's unique about that stage? And then I'm going to give you examples of strategies that can be used to help people achieve the goal of that stage. And for each stage, I will identify a specific behaviorally based goal. And it's very important that the goal is behavioral, because what that means is that if you have a treatment team of individuals and you try to evaluate a person's stage of treatment, you can have very, very high reliability on that stage of treatment because it's behaviorally based. You're not trying to intuit the person's internal motivation for change. What you're doing is you're using specific behaviors to determine that person's level of motivation. So, Let's walk through the different stages. The idea of the engagement stage is that if you want to help somebody change their behavior, you first need to have a therapeutic relationship with that individual. And until you have a therapeutic relationship with that person, you shouldn't be trying to change behavior. So that's kind of the idea behind it. Now let's, and the goal, of course, is to establish a therapeutic relationship with the person. Okay, so that's kind of what I call the clinical intuition behind the stage. Now let's get to the behavior. Okay, how do you behaviorally operationalize establishing a therapeutic relationship with someone? Well, talk is cheap. I mean, people say many things, and maybe they're motivated, maybe they're not. There are a lot of different payoffs for saying things that you might actually have limited motivation to pursue. So we're very practical. We define motivation. Well, I've gotten into motivation. I'm getting into the therapeutic relationship here. We define the therapeutic relationship as established when you're seeing the person on a regular basis. It doesn't have to be, a really, really deep relationship. But if you see the person on a regular basis, let's say you're seeing them once a week for 3 or 4 or 5 weeks, for all practical purposes, they're engaged in treatment. So rather than trying to look for a level or a qualitative aspect of that relationship, which really becomes very, very difficult to assess, simply look at the frequency of contacts is how we define engagement. Okay, well, with that in mind, what are some strategies for engaging people? Well, if they're not coming into you, and often they're not, that's where assertive outreach becomes critical. You need to go out there. And then, of course, the question becomes, well, what do you do when you're going out there and meeting and working with individuals? And here's where I say, I kind of use what I describe as the Pavlovian conditioning approach to relationship formation, which means that what you want to do is go out there and meet with people on their own turf to make them feel comfortable, and somehow, by hook or by crook, make them feel better. That might have to do with helping people get very basic needs met, like housing, clothing, shelter. It might have to do with providing better medication management. If a person is helped to get or to take medications that decrease distressful symptoms, that's a very positive thing. Just listening and talking with the individual and providing validation can be very helpful. Also, providing support to the social network can be helpful. All of those are engagement strategies that can be helpful in terms of developing a working relationship with the individual. Sometimes legal constraints are also used, such as when a person presents a grave threat to self or others. And those legal constraints can lead a person, sometimes they can result in, say, an outpatient commitment to treatment, or sometimes they may lead a person to be hospitalized. And while those legal constraints need to be dealt with therapeutically, they nevertheless represent an opportunity to develop a working relationship with the individual. But the idea is that you shouldn't be trying to change their behavior before you have some kind of a working relationship established. Now, once you have a relationship established, meaning that you're seeing the person on a regular basis, but the person's continuing to use substances, insofar as you can determine, you're into the persuasion stage. And what characterizes the persuasion stage is that you have this relationship, but there's no real agreement in that relationship that you're working together to address the substance use problems. I mean, remember that you reached out to them, you established a relationship with them, you didn't push the substance use issue, and you didn't try to change their behavior in the engagement stage. And so when you're into the persuasion stage, once you've got that relationship, the question becomes, how can you motivate that person to become interested in reducing substance use or in achieving sobriety? And so the nature of the persuasion stage is that the goal is to motivate a person to begin working on their substance use problems, which then leads to the question of, how do you know when somebody's motivated to work on their substance use problems? And this is where I began to actually talk about it a little bit earlier at the engagement stage. I was jumping the gun a little bit. But the idea being that it's really hard to know, based on what somebody says, whether they're in fact genuinely motivated to work on their behavior change. And therefore, our practical approach has been to define motivation based on behavior. And really what we're doing is we're following the example of Bill Miller, who has developed the motivational interviewing approach to helping people deal with problematic behaviors, including substance use problems, but other behaviors as well. So the idea of the persuasion stage is we'll know that somebody is persuaded that substance use is a problem and wants to work on it when they begin to make a concerted effort to reduce their substance use problems. So if we see reductions in substance use, or we see repeated efforts to reduce substances over a 1-month period or longer, we say they move from the persuasion stage into the active treatment stage. So, how can you help people become motivated to work on their substance use problems? This is actually, I would say, both the most frustrating, but also potentially the most rewarding of the different stages of treatment. And there are many, many different strategies. One thing I want to mention is I'm only giving examples of strategies. Your own creativity is really the only limitation on the types of different strategies that you can use at the different stages, as long as you're bearing in mind what the goal is. And the goal, of course, of persuasion is to persuade a person that substance use is a problem that they can conquer. So one thing is psychiatric stabilization. If symptoms are very exacerbated, it's harder to develop motivation to begin working on substance use problems. People often feel demoralized, and often their insight is impaired when their symptoms are exacerbated. So attempting as best you can to stabilize symptoms can be important. Persuasion groups is a group intervention that we've developed up in New Hampshire, in which you essentially try to create a safe haven for people to talk about and explore their substance use problems, their mental illness problems, and the interactions between the two. It's a safe place in that nobody's expected to own up to having a problem. Nobody's confronted with having a problem. If people want to talk about the positive aspects of substance use, they're allowed to. That's fine. In fact, in many cases, consumers are only willing to talk about the negative side of substance use after talking about the positive side. And so the idea of a persuasion group is you have people at the persuasion stage, but also at later stages, talking about their experience, and with the expectation that the opportunity to talk and to process the effects of substance use and poorly controlled mental illness on one's lives will naturally, over time, lead to motivation to work on substance use problems. Family education and individual education can also play an important persuasion role. Many consumers don't understand how substances interact with the biological vulnerability that we believe underlies many mental illnesses. And so by teaching people about the nature of mental illness, about psychiatric diagnoses, about the stress vulnerability model, which posits that psychiatric illnesses have a biological basis, but that biological basis interacts with the environment. And that one of the things in the environment that can trigger that biological vulnerability is the use of substances. Or the use of substances can sometimes compromise the beneficial effects of medication, for example. By teaching people about stress vulnerability, one of the things that we help them understand is that many people with severe mental illnesses have problems using drugs and alcohol, not so much because they're using a lot more drugs and alcohol than their peers are, but because they're exquisitely sensitive to even the very small amounts of alcohol or cannabis or cocaine that they may be using. This is what we call the supersensitivity model. By helping consumers understand that they're biologically supersensitive to the effects of alcohol and drugs, you open up a door for learning how to manage one's mental illness better, in part by decreasing use of substances. So psychoeducation can be a powerful, motivating strategy for individuals. I think it's especially important early on in the course of a psychiatric illness, often before substance use problems are well ingrained, and when people are still struggling to come to terms with having a mental illness and how to cope with it. There are many other strategies, and I really can't go into them in too much detail here, but let me talk about two more strategies just briefly. One about rehabilitation, and the second one about motivational interviewing, strategies for the persuasion stage. Rehabilitation, of course, refers to helping people become more functional, more adaptive, coping effectively with symptoms, getting jobs, becoming a better parent, being a better parent, and then also developing leisure and recreational activities. Well, how does rehabilitation play a role in persuading people with substance use problems to work on their substance abuse? Well, here's how. People with dual disorders typically use substances to achieve one of, and sometimes more, 4 different kinds of goals. Sometimes they use substances to cope with symptoms. Sometimes they use them to facilitate social relationships. Sometimes they use them just because it feels good. They're pretty easy to find, and consumers don't have a lot of good feelings going on, and so, hey, if you can go and feel good for an hour or two, I mean, that's pretty good, even if there is a high price to pay. And for some individuals, the use of substances in and of itself develops meaning. Those people who develop a more serious addiction, who use large amounts, it gives them something to look forward to. It structures their lives in certain ways. Well, we can give people better tools for getting those same types of needs met. We can help people cope with symptoms more effectively. We can help them develop better and more rewarding relationships with people. We can help them get back to work, get back to school. We can help them develop meaning in their lives as parents, as workers, and as students and the like. To the extent that we do that we provide rehabilitation at the persuasion stage, what we do is we undercut the need and the dependence on using substances to get those same basic needs and desires met. So the effect of rehabilitation at the persuasion stage is indirect by helping people develop better strategies for getting basic needs met, which decreases their reliance on using substances to get those same needs met. Motivational interviewing, another strategy, very useful at the persuasion stage, is basically a set of strategies designed to take the initial focus off of the destructive behavior and to focus instead on identifying personal values and goals that are important for the individual. And after identifying those goals and values, to begin the process of breaking them down, beginning to take steps towards achieving them, and in doing so, beginning to explore the extent to which using substances either helps or hinders the ability to achieve goals. Motivational interviewing is based on the observation that people are most compelled or most desirous of changing behavior when they see it as in their own best interest. And the only way really to do that is to first identify and work towards individuals' goals, and then to explore whether using substances interferes with achieving those goals. The active treatment stage. I always say by the time you get into the active treatment stage, you're almost home free. We define somebody as moving into active treatment when their substance use has reduced for at least a 1-month period of time. Now, they could still be having problems related to substance use, or they could have achieved sobriety. We say that you stay in active treatment from the time that you've reduced your substance use for at least a month until you have 6 months of sobriety. Following 6 months of sobriety, we say you go into the relapse prevention stage. So the idea of the active treatment stage is to help people reduce their substance use further, hopefully to achieve abstinence and sobriety. And it's at this stage that many of the strategies developed in for the population of people with substance use disorders become very applicable with modification to people with dual disorders. Teaching people to self-monitor, urges to use, cravings, actual use can be helpful. Social skills training for dealing with substance use situations can be helpful. Now, skills training can be useful earlier, for example, in the persuasion stage, when you focus on improving the quality of interpersonal relationships. But my feeling is that skills training for dealing with substance use situations ought to be held off until you have some evidence that the person actually wants to not use in those kinds of situations. And that's what active treatment is all about. The person's begun to reduce their substance use. You assume that they're now motivated to work towards sobriety. And so skills training to address substance use situations becomes another effective strategy. Social network approaches, family work in which you do problem solving, the identification of high-risk situations. Also self-help groups. Now, sometimes people do find it helpful to go to a self-help group like Dual Recovery Anonymous or Alcoholics Anonymous or Narcotics Anonymous. Sometimes those things are helpful at the persuasion stage, but they're more appropriate, usually, at the active treatment stage, because there's the assumption when you go to those groups that you have a motivation not to use. Now, it's true that sometimes people in persuasion are thinking about not using. They're in that kind of contemplative stage, and so it may be helpful to go to self-help groups. But it's important as a clinician not to push self-help too early. And the most appropriate role really is going to be in the active treatment or the relapse prevention stages, where you have good behavioral evidence that the person doesn't want to use. Substituting activities is another strategy, and then developing strategies for dealing with high-risk situations, social situations, problems in terms of symptom relapses, getting paid at work, things like that, and addressing motivations. And then the relapse prevention stage. We define a person as being in relapse prevention when they've got 6 months or more of sobriety. And there the goals actually become split. You want to maintain an awareness that a relapse could happen, but then you also want to begin to shift even more and to emphasize even more on other areas of the person's functioning. Their social relationships, their health, their independent living, school, work. The idea being that the more a person has going for him or her in their lives, the less vulnerable they will be to having a relapse of their substance use. And there's a lot of different strategies that can be used there. So that's the stages of treatment Of course, the stages of treatment occur gradually over periods of time. And what this figure depicts are stages over a 3-year study done in New Hampshire, study done by Bob Drake and colleagues, comparing 2 different approaches to integrated treatment for dual disorders. And what you can see is that what we've done is taken the stages concept and broken each stage into 2 substages. So, for example, engagement is broken into I think it's like a pre-engagement. Pre-engagement and engagement, and then persuasion and active treatment are both early and late persuasion and early and late active treatment, and then relapse prevention, and then we're calling recovered when a person is at the very highest level, when there's more than a year since they've met problems related to substance use. And what you can see is, from this figure, it's a little bit complicated, but what you can see is the gradual progression up the stages of treatment over a 3-year period. And a large sample, I think a little bit over 200 individuals with dual disorders. Now, sometimes people say, well, how long does it really take to get through all the different stages and so on? And of course, it's an individual matter. But one of the folks I like to quote a lot is Lindy Fox and the late Tom Fox. And what they used to say is, well, there really aren't 4 different stages of treatment. There's really 8 different stages. And those stages include engagement, 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 followed by persuasion, 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 which is then followed by active treatment and relapse prevention. So indeed, there's a lot of time and energy and some amount of frustration that happens at those very early stages, making the connection with the person and then developing that motivation. But as you can see from this study, looking at the 3-year outcomes, and we've continued following up this cohort of people, we're up to now 15 years with many of them, that more and more people over time achieve remission of their substance use problems. Okay, and the stages of treatment, we have it as a standardized rating scale, behaviorally anchored. There's a copy in the book. There may be copies on websites as well. Well, having spent some time talking about what integrated treatment is for dual disorders, let's spend a few minutes talking about research and then get to some questions. I'm going to give you a kind of a selective survey of the research literature. We're in the process of updating this survey. There are, in fact, quite a few studies. Now, if you count non-controlled studies, such as quasi-experimental studies and things like that, there's over 30 different studies that have been done. But I like to focus on the more narrowly on a few of the very rigorously done studies. And so I'm just going to talk for a couple of minutes about 6 controlled studies, and then I'll talk a little bit about directions for future research. Of the 6 controlled studies that have been done, 4 of them compared integrated versus non-integrated treatment. And then 2 of them compared different approaches to integrated treatment. All of these studies looked at fully integrated treatment programs that incorporated many of the core characteristics of integrated treatment that I described earlier. These studies, by the way, are reviewed in somewhat more detail in the book for people who want more detail on them. Godley and colleagues looked at 38 people, about half of them with schizophrenia spectrum disorders, and they compared intensive case management plus integrated treatment for dual disorders with treatment as usual. TAU is a very common abbreviation for treatment as usual. And they did a 2-year follow-up. And what they found was that the integrated treatment group had better substance use functioning at the end of the follow-up period. And there were no differences in hospitalization and symptoms. In general, in integrated treatment studies, you don't tend to find major treatment effects on things such as symptoms and hospitalizations. Although what you do find, and I'll show you a slide showing this in a moment, is that the people who achieve remission tend to stay out of the hospital and tend to have less severe symptoms than the people who don't achieve remission. Study done by Bob Drake down in Washington, D.C. on I think an entirely, I'm not sure if it's 100% or like 90+% African-American population, compared integrated treatment with treatment as usual. This was a quasi-experimental design study, which means that they got a group of individuals in one setting and they provided integrated treatment, and then they compared them to a matched group of similar individuals in another setting who continued to get traditional treatment. They had a 1.5-year follow-up, and they found that the integrated treatment program did better than the treatment as usual folks in terms of stages of treatment and the severity of their alcohol problems. There were no differences in drug severity, hospitalization, symptoms, and other outcomes. And then in a study done in several mental health centers in Texas by Carmichael and colleagues, they looked at 208 clients, 31% with schizophrenia, randomly assigned to either integrated treatment or treatment as usual. And they found much better outcomes for the integrated group across a range of different areas, including alcohol and drug severity, adherence to medication, arrests, income, and satisfaction. And there were no differences in some of the other clinical outcomes. And Christine Barraclough and Nick Terrier and their colleagues, what they did was they looked at an integrated treatment program that included a family intervention component and an individual psychotherapy component that blended cognitive behavior therapy for psychosis with motivational interviewing, a pretty unique package there. And they studied it in 36 individuals with schizophrenia and substance use problems, and they compared this integrated treatment program to a treatment as usual program. And they did a one-year follow-up, and now there's a longer-term follow-up that's recently come out. And they found that the integrated treatment group had better outcomes in terms of days abstinence, hospitalization, and symptoms. Now what's interesting about their study is that their integrated treatment for dual disorders specifically targets certain persistent symptoms in addition to working on substance abuse. And that might be one of the reasons why they got a main effect on symptom reduction. And then that leads us to a couple of studies looking at different approaches to integrating treatment. There was a study by Jarrell and Ridgely that looked at 3 different approaches to providing integrated treatment for dual disorders. One of them was a social skills, or they called it a behavioral skills training approach, where they taught skills thought to be specifically relevant for dealing with substance use problems. That was then compared with an intensive case management approach, and that was then compared to a 12-step approach. And they found pretty good outcomes for everybody, but the outcomes were best for the skills training group. They were intermediate for the intensive case management group, and they were least positive for the group of people who got a kind of adapted 12-step approach. And then last study done by Bob Drake, I referred to this one earlier, done at 7 different mental health centers in New Hampshire, looked at 2 different approaches to delivering integrated treatment. One approach was delivering integrated treatment in an assertive community treatment team, and then the other approach was standard case management. Now what was interesting about this study is that everybody got a package of integrated treatment services. So it's really a test of the delivery system rather than of the services themselves. They had a 3-year follow-up. And essentially what they found was that the effects of the integrated treatment as delivered in the ACT model were modestly better than the effects of integrated treatment as delivered in a standard case management approach. In general, people in both of the different services did quite well. The overall rates of remission of substance abuse over the 3-year follow-up period were somewhere in the 45% range, quite a bit higher than what surveys indicate one would find in services as usual. Now from this study, one of the things you could see is if you compare the people who achieved remission versus the people who didn't, people who achieved remission had more stable housing in the community, just what we would expect. And similarly, people who achieved remission were less likely to be hospitalized. This is kind of the mirror. It's not the perfect flip image because there's other ways of not being stable in the community without going into the hospital. But just as we expect, achieving sobriety is associated with better clinical outcome, less severe symptoms, less hospitalization. And another thing that's interesting about this study, because it was done at 7 different mental health centers, is that what they found is that the quality of assertive community treatment, with quality defined in terms of fidelity to a standard measure of how assertive community treatment is supposed to be delivered, was related to outcomes. Centers that had the highest fidelity tended to have better outcomes in terms of substance abuse over time than centers that had lower fidelity. And so what they did was they divided the 7 different sites into high versus low fidelity. And you can see that the outcomes of the high fidelity programs, as reflected in the blue line there, were significantly better over the 3 years than the outcomes of the people in the low fidelity programs, as reflected in the pink lines. There are lots of limitations to this research for any doctoral dissertation candidates out there, people looking for good areas to do research. You don't have to worry about everything already having gotten answered in this field. There are lots of questions. In fact, people even sometimes have debates. Is this an evidence-based practice or not? And without coming down on that on one side or another, there certainly is mounting evidence that integrated treatment is more effective than non-integrated treatment, but there's need for much better research. Among other things, that many of the studies that have been done, the interventions were not well standardized. Fidelity was not routinely assessed in many of the different interventions. So far, there's no actual replications of effective programs, and replication really being the heart of science. It's hard, at least for me, to be totally confident about something until I've seen it replicated. And the control conditions were highly variable and sometimes not well defined. So there's lots of good work that needs to be done in this area. Just to very briefly highlight two areas of research that we're doing, and these are kind of ones that you can kind of keep your eye out on. One of them is looking at a family intervention program that we've developed for people with co-occurring disorders. And what we've done is we've developed an intervention program called Family Intervention for Dual Disorders, for lack of a catchier name, the FID program. We tried to come up with a sexier, cuter name for it, but nobody could agree on it. So finally, it's just called the FID program for now. And what we do in that is we combine behavioral family therapy, specifically focused on helping families learn how to manage co-occurring disorders, with multiple family support groups that are done on a monthly basis. And sessions can be done either at home or in the clinic. And the purpose of the behavioral family therapy is to teach basic information and skills about the management of the psychiatric illness and the substance use problems. And the purpose of the multiple family groups is to provide support, to do group-based problem solving, and to maintain a long-term connection with the treatment team. These are the phases of behavioral family therapy. I'm not going to go into that, but just so you know, behavioral family therapy is a learning-oriented intervention designed to teach families, and we always include the consumer in the family, of course, to teach families about mental illness and the principles of its management, to help improve communication skills, and to teach a structured approach to solving problems that maximizes collaboration and minimizes tension. And these are just the results. You don't have to look at them in detail now, but these are the results from a pilot study that we did of the behavioral family therapy program. And what's depicted here is the stages of treatment that I referred to earlier for each of 6 different individuals who were in the study. And what you could see across all 6 individuals were improvements in stages of treatment. And if you want to know, hey, what does it really mean? Remember that each stage is divided into 2 substages, and that going from late persuasion to early active treatment reflects a significant reduction in substance use. So when somebody reaches a 4 in this, that's late persuasion. That's when they begin substance use reduction. When they hit a 5, that's sustained substance use reduction. So that's one way of looking at that. And then this is just another figure from the same study looking at substance use problems using our clinician rating scale. And on this clinician rating scale, a 3, 4, or 5 refers to a substance abuse, substance dependence, or severe dependence. So what you can see from this is most of the people actually, by the end of 2 years, getting below a 3, no longer having an active substance use disorder by the end of the pilot. And then last of all, who ever heard of antabuse in people with dual disorders? In fact, doctors are afraid to use disulfiram, which has got the brand name of antabuse, because there have been early reports about antabuse exacerbating psychotic symptoms. So we did an open trial, simply looking at people in the New Hampshire system who had been prescribed antabuse, and looked to see how often did antabuse exacerbate psychotic symptoms? How often did it play a critical role in helping people achieve sobriety? And so in this study, we looked at 33 individuals, 70% with schizophrenia or schizoaffective disorder, who had treatment-refractory alcohol problems. And we looked at what the effect of simply prescribing antabuse was for these individuals in terms of their substance use problems. And what we found was that actually the majority of them tried some amount of drinking on antabuse. 28% experienced negative reactions to drinking. You might wonder, why didn't a higher percentage experience negative reactions? Probably because very moderate doses of antabuse were used in this study, 250 milligrams for most people. And the dosage can be pushed to higher levels, 500, 750. But there was an understandable kind of conservatism in the dosage ranges that were used. We didn't find any examples of antabuse prescription being associated with an exacerbation of psychosis, nor were there any serious medically adverse effects associated with drinking when a person was taking antabuse. So that's kind of the feasibility. But look at the outcomes. What you can see is that over 3 years, the outcomes were really very good, with the majority of people showing significant remission of their alcohol use problems. And this is days in the hospital. As you might expect, drinking, reduction in drinking was associated with spending fewer days in the hospital. Overall, 63% had a remission of their alcohol abuse for at least 1 year. 30% had a remission for 2 years. People often showed remissions of drug use as well. So I think that this is kind of a promising, kind of an interesting study, considering how little antabuse is actually used. For people who would like to see the full report of this, it came out last year in the American Journal on the Addictions. I was the lead author. But to me, it suggests that somebody needs to do some controlled research on this. And so to wrap it all up, substance use problems are very common in people with severe mental illness, and they're associated with a wide range of different negative outcomes, precipitation of relapses, medical problems, family stress, economic problems, legal problems, and the like. Integrated treatment programs are defined in terms of interventions designed to treat both disorders at the same time by the same clinicians, and with a particular focus on the interactions between those. And early research on integrated treatment is promising, shows that it's associated with better outcomes than traditional segregated, parallel, or sequential treatment approaches. So I don't know how much time we have, but I'd be happy to take a few questions.
I have a question. In your discussion of phases of treatment, the introduction of work or vocational goals, I guess, came at the very end. Can you just talk a little bit about that?
Yes. It came at the end more, or just actually to repeat the question, the observation was that in looking at the different stages of treatment, our first mention of work really came in the relapse prevention stage. And one might quite reasonably wonder, well, does that mean that we encourage people to put off the search for work until they've achieved sobriety? And the short answer to that is no. The only reason we brought it up there is to talk about an increased focus on those kinds of things. But in the same way that helping people develop better relationships with other people, helping them become better parents, helping them get back to school, in the same way that those become motivations for not using substances, getting back to work, or keeping a job. Often what happens is somebody wants to go to work, they're still using, you might be skeptical, is the using going to interfere with the work? But you don't want to, run the person's life. It's the consumer's got to make the choice. And so it's actually much more effective for the person to go back to work if they begin to experience substance use as interfering with the work, to use that and to process that clinically with the consumer, with the hope of developing motivation to begin working on the substance use. So the answer is that work, in fact, is often addressed early on in the course of integrated treatment for dual disorders. There's conflicting evidence as to whether having a substance use problem interferes with the ability to get work in supported employment programs. Several studies indicate that there's no interference whatsoever. There's some studies indicating that there is some interference. In a study that we recently did in Hartford, we did see that the people with alcohol use problems had somewhat lower rates of getting jobs. About half the people with alcohol use problems got jobs, and about 83% of the people with alcohol problems got jobs. So there's something going on there. But half the people got jobs, so I kind of I think it's a very positive kind of a thing. So my belief is that work and also the return to school are such important motivational factors that often they need to come into the dual disorder treatment process earlier rather than later. And our belief collectively, within the group of people that I work with and co-authored the book, is strong enough that we have a chapter actually focused just on vocational rehabilitation in the dual disorder book.
Kim, I was just curious as to whether and this just from your own personal experience and knowing some of the subjects that you've worked with over the years, is there any factor involved with people sort of aging out of use as they mature age-wise that you see differences?
Yeah, I think that's a great question. To repeat the question is there any evidence that there is a natural aging process in substance abuse? And what's interesting first is to consider, well, what do we know about the general population? And when you look at the rates of substance use problem and kind of the natural aging process, there in fact is a lot of evidence that many individuals naturally age out of substance use problems in their late 20s and their early 30s. And I think one of the reasons why this may not happen as much in people with severe and persistent mental illness is that often there's a kind of a quality of arrested social and role development that occurs when a person develops a mental illness. In fact, there's very interesting research that shows that the level of a person's role functioning when they first become ill is relatively predictive of their level of role functioning after they've developed the illness, that they don't tend to go a lot higher. Now that doesn't mean without rehabilitation we couldn't help people get higher. But I think what happens in effect is that sometimes people get kind of arrested in a kind of a psychodevelopmental stage, and that part of being stuck in that stage is the substance use. So we do see over time sometimes people just kind of giving it up, getting tired of it. But my belief is that the best way to facilitate that process is to attend to role functioning, help them get, well, first of all, developing hope and belief that change is possible, really supporting that self-efficacy, reframing past experiences as valuable lessons, helping people conceptualize themselves as survivors, as copers and things like that, and then helping them move forward in terms of identifying and pursuing goals. And because then that gives you something to motivate the person around. And often what happens is that they then experience the substance use interfering with the achieving of that goal, and that's how you develop and harness motivation to work on the substance abuse. And to me, it's a way of kind of tweaking that natural developmental process that often happens in people who don't have a substance use problem. Yeah.
Kim, have you considered including any alternative therapies in your integrated treatment model, like acupuncture, for example? And my second question is about the 12-step philosophy and principles. What role they play in your treatment model?
Good questions. The first is the use of alternative treatments. Our model is more of a conceptual framework than it is a specific set of programmed interventions. So I think that you could have a program that included alternative therapies, whether they were herbal medicine, yoga, acupuncture, and things, and that they might really fit an important role. In fact, I think any program that helps people deal and cope more effectively with stress, and that develops a greater awareness of both oneself and the greater world around them, I think that those programs are likely to be beneficial to people with dual disorders. We haven't incorporated them, I guess partly because we don't have a lot of expertise in that. We already got 20 chapters in the book and nobody wanted to write a 21st chapter. So I don't think it's so much that people don't believe it doesn't work or are kind of prematurely rejecting it as much as that it's wide open, and so far there hasn't been that much work in those areas, to my knowledge at least. We tended to focus on certain areas that we knew things about and were either adapting what we were doing from the kind of the psychiatric rehabilitation perspective or taking interventions from the substance abuse field. With respect to the second question, which is well, where does the 12-step philosophy, what do we think of it? First of all, we do encourage people, especially when they get into active treatment, to at least explore self-help options. And by far the most widely available self-help option are the AA type groups, Alcoholics Anonymous or Narcotics Anonymous type groups. Now there have been modifications of those groups that are more specifically tailored to people who also have a co-occurring psychiatric illness, such as Dual Recovery Anonymous, although those are somewhat more difficult to find. So we recognize the fact that significant numbers of people with addiction benefit from the basic AA philosophy, the spiritual focus, and things like that. At the same time, we're also aware that significant numbers of individuals with co-occurring disorders seem to be less drawn or find less benefit from those approaches. And in our own data, those individuals, the people with schizophrenia spectrum disorders, in fact, are less likely to go to those kinds of groups and report less benefit from them. I think for a variety of reasons. One is that because the groups are sometimes large, there's a heightened level of social anxiety in those individuals. A second thing is that sometimes I think that the spiritual focus of those groups can be confusing to individuals who themselves may have beliefs involving spiritual themes that may be related to their psychiatric illness. At the same time, turning it around, it's probably safe to say that the psychiatric rehabilitation field has ignored or not sufficiently attended to the spiritual needs that people with psychiatric illnesses and dual disorders have. And so connecting people to those groups may, in fact, help meet some of those needs. Sometimes kind of the rigid philosophy and some of the abstract concepts that are incorporated in that philosophy can be a little bit difficult to grasp for people with thinking difficulties. So all of that put together, we look at 12-step approaches as a valuable approach, and we will sometimes incorporate elements of 12-step approaches. But we don't take a kind of a hardcore doctrinaire approach in which we more or less say, this is the way. I mean, our belief is that many people get better, or that people with dual disorders get better following a variety of different paths. And really what's most important is helping each person find and define their own pathway. And so for some people, the 12-step approach really is a tremendously helpful pathway, and one that's got tons of social support for following. But for other people, it may be a very different pathway, and that's fine. We're very, that sits very well with us.
I'll pose the last question, which is, did you measure readiness for change in the anti-abuse study? And if so, what role might that have played in the positive outcomes you saw?
The question is whether we measured readiness for change in the anti-abuse study, and the answer is no, not other than getting stages of treatment. But we did not use one of the stages of change measures like the Socrates or something like that. And to be honest, some of the people in the anti-abuse study I believe were on conditional discharges from New Hampshire Hospital. So, and part of the conditional discharge was agreeing to anti-abuse therapy. So there's no doubt that some coercion was involved in treating some of those individuals. I forget the percentage. I think it may be as much as a quarter or a third of those individuals. In most cases, they were individuals who had persistent alcohol problems despite receiving really quite state-of-the-art integrated treatment for dual disorders, including outreach, persuasion groups, a certain amount of family work, things like that. And so what we find the toughest sell for anti-abuse is the professionals, not the clients. I mean, there's certainly clients who say they don't want to use it and the like, and you have to respect that. But we found in certain settings that we've worked, there are professionals who won't even put it on the table. They won't even consider the use of it because they're concerned either of medical consequences of what happens when a person drinks. And that's why I think that the series of 33 people was interesting, because we didn't see anybody who had any significant medical reactions, and concerns about precipitation of psychosis, which there were a few case reports very, very early, primarily in the 70s, about anti-abuse precipitating psychotic symptoms in people who didn't have psychotic disorders. But as I described, we didn't see that in any of the 33 people that we treated.
All right. Let me just take this opportunity to thank Kim again for this wonderful presentation. And thank you all for joining us here at the Center for Psychiatric Rehabilitation.